Well, let's switch back to you, Dr. Carrero. You're going to guide us through the essence of your scientific work here in Stockholm. What have you been working on?
Sure. The main interest of our group here in Stockholm is inflammation, and I have been focusing more on the relationship between inflammation and malnutrition. And the first thing that I have learned is that chronic kidney disease, and you may all agree with me, is a very complex disease. And we tried to show that with this puzzle that we published earlier this year, where we picture uremia as a big puzzle in which we know many things that are working, that are affecting our patients, like typical risk factors or inflammation or malnutrition or endothelial anti-infection, but still there are many things that we do not know. And the proof of that is that we have not improved much the survival of our patients. So basically we know that up to now, almost everything impacts in chronic kidney disease. Basically from problems in the brain, the sympathetic activation, to volume overload, bone disorders, muscle disorders, fat mass, adipokines, and everything may be gathered by the common link of inflammation, which is the hidden driving force that I believe that moves all these things around. So we performed some studies in how inflammation may lead to wasting, and one of the first ones was dealing with the impact of appetite loss or poor appetite. So we just studied a very common symptom in our patients that is also connected to a very strong impact in survival. Just reporting to have a poor appetite is going to make you die much faster than any other patient. And we could see that in these patients with poor appetite, a decrease in appetite was followed by very much increases in the inflammatory markers. And we know that there are a lot of peptides, pro-inflammatory cytokines, uremic toxins that affect appetite, and who knows what other molecules might be affecting the appetite of our patients, and we still do not know. So the first question that it came after this paper is, could we reduce inflammation by treating the appetite of our patients or vice versa? That could be an interesting follow-up. Okay. Then the next work we performed was related to the effect of thyroid dysfunction, of alterations in the thyroid hormones. Because following some of the hypotheses of Carmine Zoccali in Italy, there are consistent evidence in the general population that any alteration in the thyroid status, hyper or hyperthyroidism, would develop in an increased risk of cardiovascular mortality. And that is funny or sad, because 1/4 of our patients have abnormally low levels of thyroid hormones, basically because the kidney impairs the conversion of T4 into T3, the lack of kidney, I mean. So what we did was to study the levels of thyroid hormones in euthyroid patients in chronic kidney disease, starting dialysis. Patients that do not have any alteration in the thyroid hormones, they have normal levels, and there is no reason to intervene. And still in these patients, those that presented lower levels of T3 have a much worse all-cause and cardiovascular mortality. And that was in part perhaps explained by the strong link between pro-inflammatory cytokines and T3 levels. So the question that came from here is, could thyroid hormone replacement therapy be a potential target to treat not only malnutrition, but also inflammation in our patients? The third aspect I worked with was with muscle catabolism, another inflammatory mediated process, which is quite common in our cohorts. It's in about 30 to 40% of our patients will present some sign of muscle atrophy, and that is also followed by increase in all inflammatory markers, and it's also a prognostic indicator of the survival of our patients. And we tried to study some new molecules that have been recently discovered, like, for example, TWIC, and this is a collaboration with Spain, in which it's a very potent muscle-wasting cytokine. There's very little information about that, but we hypothesized that a very worst scenario in which TWIC that induces muscle wasting and IL-6 that also induces muscle wasting will be both increased, would lead to a much worse survival. So this is what we could see in this study that we have just submitted, where the patients with both elevated IL-6 and TWIC have additive effects on the mortality, working in a synergistic manner. And that may be through an exacerbation of the muscle wasting, because this group with this special condition showed the lower hand grip strength, the lower muscle mass, and the lower IGF levels. So it's still very early, but could be be a therapeutical target also here. Finally, other of the aspects that we work with is the telomere attrition, or the connections between the telomere length, the cell aging, and the inflammation, because there are some studies showing that in the general population, even in the absence of any disease, presenting shorter telomeres than your age-matched controls will predispose you to have cardiovascular disease. This is a disbalance between the chronological age and the and the age of your cells. So we knew nothing about what happens with chronic kidney disease. So we measure the telomere length in our patients, and we could see that presenting the short telomeres, it's a light gray line, was also predisposing to a much worse survival. That was as the correction for age, of course. And we also noticed a very strong negative association with inflammatory markers. So I don't know what I would like to continue that. There was a very nice link to calcification, and we are now trying to work with Germany, with the Aachen group, to replicate these findings and expanding this knowledge. So what I can say that I have learned, or what we have achieved up to now, is that we have identified new pieces in this complicated puzzle, like poor appetite, thyroid disturbances, cell aging, or some inducers of muscle wasting. We have just generated new questions, and however, we are still far from providing any answers, and that might take a very lot of time. And I hope that if I can make it in this world of research, I could contribute to give some more answers and some more questions.
Okay, well, good luck to you with that research, and congratulations once again, Dr. Carrero, Dr. Yilmaz, Dr. Chmielewski. Thank you.
Thanks.